Welcome back. In Part 1, we built the skeletal foundation of the spine. Today, we construct the soft tissue architecture. We are going to build this system block by block, layering the anatomy from the outermost surface directly down to the spinal cord. Memorizing a list of muscles won't help you in a clinical setting. You have to understand the specific topographic layers to accurately diagnose complex presentations. The exact physical placement of these tissues dictates how localized nerve compressions manifest and the precise pathways malignant cells use to spread. We will start with our first block of study, the functional stratification of the back musculature. Treating the back as a literal engineering schematic is the only way to master procedural anatomy and understand board-level pathology. Let's examine this posterior illustration showing the superficial extrinsic layer of the back. This group consists of the trapezius, the latissimus dorsi, the levator scapulae, and the rhomboids. Developmentally, these are upper limb muscles that migrated onto the back during embryonic development. Because of this origin, they follow a specific wiring rule. They are innervated by the ventral primary rami of the spinal nerves. The notable exception is the trapezius, which is supplied directly by a cranial nerve, the accessory nerve. Moving one layer deeper, we find the intermediate muscles, the serratus posterior superior and the serratus posterior inferior. These intermediate muscles serve a distinct mechanical role in respiration. They attach directly to the ribs, elevating and depressing the rib cage to assist in breathing. Both the superficial and intermediate layers are classified as extrinsic. They operate the upper limbs and the respiratory system. They do not maintain the structural stability of the spine itself. This cross-sectional diagram reveals a deep intrinsic layer, the true muscles of the back. The largest group here is the erector spinae, divided into 3 columns, the lateral iliocostalis, the intermediate longissimus, and the medial spinalis. Unlike the migrated extrinsic muscles, these intrinsic muscles receive their signals entirely from the dorsal primary rami of the spinal nerves, which project backward to innervate them. Beneath the erector spinae lies the deepest muscular tier, the transversospinalis group. Composed of the semispinalis, multifidus, and rotatories, these short muscles run between adjacent vertebrae to provide fine rotational stabilization. If we follow this deep layer superiorly to the base of the skull, we hit a high-yield clinical area known as the suboccipital triangle. This space is bounded by 3 specific muscles, the rectus capitis posterior major medially, the obliquus capitis superior laterally, and the obliquus capitis inferior below. We map these borders carefully because of the critical structures trapped inside the triangle: the first cervical spinal nerve, the suboccipital nerve, and the vertebral artery ascending into the cranial cavity. This entire intrinsic layer forms the structural core of the body. Relying exclusively on dorsal rami wiring, it maintains our upright posture and stabilizes the cranial vault. Look at the schematic of the neurological wiring. The spinal cord emits dorsal and ventral roots that merge within the intervertebral foramen to form our 31 pairs of spinal nerves. Almost immediately, the nerve splits again. The massive ventral primary rami extend forward to form the complex brachial and lumbosacral plexuses, while the much smaller dorsal rami remain localized to innervate the deep back. This precise wiring creates dermatomes. A dermatome is an area of skin that receives its sensory innervation strictly from a single spinal nerve segment. On the sensory side of this pathway, we find the dorsal root ganglion. This structure houses the cell bodies of the sensory neurons, carrying signals from those dermatomes back to the spinal cord. This ganglion is the exact site where the varicella zoster virus, the cause of shingles, remains dormant for decades. When the virus activates, it travels outward along the sensory nerve, producing a severe, painful vesicular rash on the skin. The dermatome map is a diagnostic tool. Because the virus strictly follows its host nerve, a clinician can look at the physical location of the rash and instantly identify the exact compromised spinal segment. Let's examine the vascular network. The arterial supply descends in a predictable pattern, moving from the occipital artery in the neck down to the segmental intercostal and lumbar arteries feeding the lower back. This schematic displays the internal vertebral venous plexus, which forms a ladder-like configuration running through the epidural space, connecting with the external plexus outside the vertebrae. Clinically, this network is known as Batson's plexus. Its defining anatomical feature is that it is entirely valveless, meaning blood can flow freely in both directions. Routine physical actions like coughing, sneezing, or heavy lifting cause sudden spikes in intra-abdominal pressure. Because there are no valves to stop it, this pressure forces venous blood to flow backward into the vertebral plexus. This bidirectional flow has severe implications in oncology, particularly for patients with pelvic malignancies, such as prostate cancer. Batson's plexus acts as a direct anatomical loophole. When pressure forces blood upward, cancer cells from the pelvis can travel directly into the vertebral column and the brain, entirely bypassing the body's pulmonary filtration system. We apply this structural knowledge to clinical pathology by examining the intervertebral disc. It consists of a tough outer fibrocartilage ring called the annulus fibrosus and a central, shock-absorbing mucoid core known as the nucleus pulposus. In a slipped or herniated disc, the annulus fibrosus ruptures. This allows the internal nucleus pulposus to extrude into the spinal canal. Because the posterior longitudinal ligament reinforces the midline, these herniations typically occur posterolaterally. As seen here, lumbar spinal nerve roots descend obliquely within the subarachnoid space before exiting through their intervertebral foramina. When the L4-L5 disc ruptures posterolaterally, the bulge misses the L4 nerve, which already exited laterally. Instead, it directly compresses the descending L5 nerve root. This specific compression triggers L5 radiculopathy. The patient experiences this as sciatica, radiating pain, muscular weakness, and tingling straight down the L5 dermatome in the lower leg. Because of this oblique descent, the clinical symptoms in the lower limb will consistently point to a structural failure one vertebral level higher than the locally exiting nerve suggests. The ultimate test of this three-dimensional anatomical framework is executing a lumbar puncture. The procedural target is to extract cerebrospinal fluid from the subarachnoid space. To perform this safely, the needle must enter below the L2 vertebral level to avoid striking the conus medullaris, the terminal end of the spinal cord. Let's trace the needle's exact path. Entering posteriorly, it pierces the skin, thoracolumbar fascia, supraspinous ligament, and traverses the interspinous ligament. The needle reaches a critical threshold, the ligamentum flavum. Pushing through this elastic tissue provides a tactile pop, indicating entry into the epidural space. From here, depth control dictates the procedure. Stopping here allows for epidural anesthesia. Pushing further means piercing the tough dura mater and the arachnoid membrane to finally reach the cerebrospinal fluid in the subarachnoid space. Differentiating a superficial muscle strain from a severe structural radiculopathy or executing a flawless spinal tap relies entirely on your ability to visualize and master this sequential, three-dimensional neuromuscular grid.